So Nunkri Nungi, everyone. Nanawai Mechi Paul Worley, Napi Puteri Maori Pomerank Unk, and Nunajeri Rui. I'm coming to you today from Nunajeri country in Murray Bridge at the Murundi Aboriginal Community Health Centre on Adelaide Road. And it's fantastic to be back together as an academy with the opportunity to learn from people within, learn from people without, and all the time trying to improve the care that we can provide to rural people in our region and around the world. Paul Worley is my name. I'm the Executive Director of Clinical Innovation here at Riverland Mallee Coorong Local Health Network. And we're very fortunate today to have one of the registrars in our region who has done some quite significant work in one of our regional centres in South Australia. And I think it gives an example of the impact that registrars can have in a health service with fresh eyes, new ideas, and working alongside experienced people with local knowledge. I hope you enjoy hearing the work that Carmen has done. Dr Carmen Hayward is an RG trainee currently at Berry Medical Clinic, and has also done her public health training, and she's going to talk about that today. So Carmen, welcome, and over to you.
Thank you, Professor Worley. Hi everyone, I am presenting today on a project that I completed whilst working in Port Pirie, and that was the development of a clinical practice guideline for management of elevated blood lead in a lead endemic city, which was Port Pirie. But before we start, I'd like to acknowledge the traditional owners of the land on which we work and live. I pay respects to the Aboriginal custodians of the land and waters within the York and Northern Local Health Network, which I have worked within to develop the project I'm presenting today, and also to the places where most of us are today within the Riverland Mallee Coorong Local Health Network. Okay, so a bit of a background here to start. So I originally took a job in Port Pirie beginning 2022 as a secondment from the Riverland, because the Department of Health and Wellbeing, who work very closely with the Environmental Health Centre, or EHC, in Port Pirie, were looking for an interested medical person to get involved at the centre. And Professor Worley, who has just introduced me, he reached out to me because he wanted to see if I was interested. And because I had an existing interest in environmental health, of course, I took this opportunity. And so from there, I worked for the next few years on a part-time basis for the EHC. These are just some photos from one of the very many road trips I took to get there from Berry, which I did each fortnight. And then getting accepted into the advanced training program in public health, that was the beginning 2023. I worked on getting the EHC accredited as a training site for this training program, and we were successful in doing this, which was great. So in this context, I really got stuck into my projects there until I finished my placement there in February this year. So today I'm going to be talking about the biggest project that I completed during my time in Port Pirie, and that was the development of the Port Pirie Clinical Lead Guideline. So bit of background, Port Pirie lies 300 kilometres to the northwest of the Riverland in the mid-north of South Australia. It's located on Nakanu country. It's home to over 17,000 residents, and that includes 4,500 families. And for about 2.5 years, I travelled regularly there to see what I could do to address some of the public health challenges that face those that live in this lead endemic city. So a bit of a history lesson is in order at this point. Now, in 1884, silver and other minerals were discovered in the barrier ranges at Broken Hill. And this led to a battle for what was then known as the barrier trade. Eventually, the train lines started carrying lead ore to Port Pirie. And this dramatically shaped the future of the town, because in 1888, the decision was made to begin smelting the lead in Port Pirie instead of at Broken Hill. The site that was chosen was close to the centre of the town. It had easy railway access. And so in 1889, the lead smelter began its operation. And it has been operating and expanding ever since that time. It's still very much in the centre of Port Pirie. It's located on the Port Pirie River, which is a tidal inlet near the northern tip of the Spencer Gulf. And in this historical context, you have a lot of contaminated soil, buildings, and river sediment. These are sources of legacy lead in the environment. And then you've got the continued operation of the smelter. So that's an ongoing source of lead in air contamination, which is dispersed as dust throughout the city. It's deposited on people's homes and properties. Okay, now in response to that, the South Australian government established the lead implementation program, and that's been operational since 1984. It's delivered through the Environmental Health Centre. So the EHC, which is within the York and Northern Local Health Network in Port Pirie, and they focus on a voluntary blood lead testing program, along with family and community support services. And this includes home lead contamination assessments and assistance to people with strategies to minimise their exposure. This is a photo of the team last year. So that's me in the front with my daughter on the left there. She came with me for the road trip on that occasion. Okay, the National Health and Medical Research Council, they provide the Australian recommendation that where a person has a blood lead level greater than 5 micrograms per decilitre, the source of exposure should be investigated and reduced. Now, looking at this graph here, blood lead monitoring within the EHC suggests that around 2/3 of children aged below 5 years in Port Pirie have a blood lead exceeding this. And this is an even greater proportion when you look at children aged 2 years. I believe the 2024 report has just been released. So this is the 2023 report. But as you can see, there's a lot of work to be done to try and get those levels lower. So a little bit about lead, for those of you that don't know. It has no role in the body. It's been associated with a diversity of health outcomes. Most research is focused on neurological outcomes following childhood exposure and cardiovascular outcomes for adults. Now, estimates by the WHO suggest 30%, so 30% of the global burden of idiopathic developmental intellectual disability can be attributed to lead. And as well as that, 4.6% of all cardiovascular disease and 3% of all chronic kidney disease worldwide. Now, children and pregnant women are our population targets when we think of needing to protect people from the harm from lead. Vulnerability in the paediatric population lies in the fact that, firstly, the neurotoxic effects of lead are observed with lead exposure in utero and during infancy and childhood, and then deficits in neuropsychological function can persist throughout life. There's no placental barrier for lead, so the maternal blood lead level closely matches what the fetal blood lead level is. Secondly, you've got children's normal behaviours. So a normal child puts their hand to their mouth all the time, and this facilitates ingestion of lead-contaminated surface dusts. And then thirdly, if you look at the gastrointestinal absorption of lead, it's higher in children than in adults. So 40 to 50% of what's swallowed is absorbed in infants and children, compared to only about 3 to 10% in adults. This might reflect a combination of physiological, behavioural, or dietary differences. But important to note there that the primary mechanism by which lead enters the body for the general population in Port Pirie is through swallowing it. So it's different to some of the occupational exposures where inhalation might become an issue. Here we're thinking of what's swallowed. All right, so once it's absorbed from the gut, it's carried in the blood to be distributed in soft tissues and bone. So bone is primarily where it's stored. Blood lead has a primary half-life of 30 to 40 days. It's excreted primarily in urine, feces, smaller amounts lost in saliva, sweat, hair, breast milk, but bone is the major storage site. It has quite a highly variable rate of elimination back into the blood. It depends on lots of different factors, like how labile the bone is, the person's age, how intense their lead exposure was. But the chronicity of exposure for residents in Port Pirie is important to consider here, because bone will comprise more than 90% of the body's burden of lead in adults and more than 70% in children in this context. And then when you have periods of increased bone metabolism, and this includes pregnancy following a bone fracture, with aging, lead is released back into the blood and the blood lead level will rise. Now, just a little picture here of the hospital. You can see there's the lead in the background there. You've got one of the smokestacks from the smelter works. And I just wanted to take this opportunity to just talk about a patient or a man who gave us a call at the Environmental Health Centre one day. He was in his 70s. He'd worked at the lead smelters for most of his life. He was retired at that point, but he'd had very high blood lead levels throughout his time working in the lead smelters. And he talked to us about the fact that he just couldn't get his blood lead level to go below around 15 micrograms, which is high. And he had this, quite bad neuropathy in his feet, aches and pains. And he said, look, I don't know where my lead exposure is coming from. And what we were probably seeing was that high exposure throughout his life. His bones would have been holding a lot of lead. With normal aging, you get, loss of bone density. And that picture was really probably the lead coming out back into his blood and keeping his blood lead level, elevated. So it's quite interesting to when you know the pathophysiology of how it all works. So now we come to the reason why I embarked on this project. So I was the first public health medicine trainee and the first medical person at all really to work within the EHC. And it soon became apparent to me that some of the most important work that can be done to mitigate harmful exposure to lead for individuals in Port Pirie was being done here at the EHC. However, the burden of relaying the important messages about lead to the community seemed to fall perhaps somewhat unfairly, just mostly on the EHC. And a lot of the primary healthcare clinicians that I got to know in the city, they didn't know much at all about the lead situation or what to do about it for their patients. And many of these patients were referred to them by the EHC because they'd been identified as having a raised blood lead level. And so I wanted to help facilitate a shared responsibility for minimising the adverse health impacts of lead in the community of Port Pirie, and just improve knowledge among clinicians around the health implications of exposure to lead and provide some best practice guidelines for managing it. So I visited each of the GP clinics in Port Pirie many times, and the GPs are always really keen to ask questions about how they should be managing the patients that they see with high blood lead. And this was quite a tricky scenario because I'm not a toxicologist or a paediatrician or any other clinical specialist who's placed to answer those questions. And it didn't take long to realise that what was missing was a clinical guideline that these doctors in Port Pirie could refer to for managing patients that are chronically exposed to a high lead environment. But not only doctors, because it soon became apparent that other clinicians, especially midwives and other community allied health workers, they would also benefit from a clinical guideline that had some local context. And so the objective of this guideline was to provide clinicians with clear recommendations for minimising the adverse health impacts of lead in the community of Port Pirie. Now, within the NHMRC, they have published a guide for health practitioners in Australia for the management of individuals with elevated blood lead, but it explicitly states that it's not intended for use in communities where lead is endemic, such as occurs with smelting. And furthermore, it doesn't constitute a clinical practice guideline. So I needed to scope the literature, find out what was out there in terms of a clinical guideline for managing elevated blood lead levels. And I needed to consider how existing guidelines could adapt to work in the context of Port Pirie. Now, in Australia, a number of clinical guidelines did exist. One in particular was within the lead endemic area of Broken Hill. I took these to the GP clinics in Port Pirie and I just asked the GPs what they thought of each of them. So I explained that I was embarking on a project to develop something similar for Port Pirie and I wanted to know what they wanted. And it was fairly clear that the Broken Hill clinical lead guidelines were the favourite. And I was in luck because paediatrician Dr Garth Alperstein, who was doing the annual reviews of this guideline, was contactable. He was very happy to share some pearls of wisdom with me and formulate a plan of how I was going to go about creating something similar for Port Pirie. So subsequent to that, I reached out to other experts in South Australia in the fields of toxicology, paediatrics, obstetrics, midwifery, general practice, community and allied health. And I managed in the end to form a working group with 15 other professionals across all of these fields. And they all provided advice, input, feedback throughout the development process. Some of the key players here worked within the Royal Adelaide Hospital toxicology team. And with their assistance, I was able to gather and critique the information within some key clinical lead guidelines that currently existed. And most notably, this was the WHO guideline for clinical management of exposure to lead, the CDC US recommendations for follow-up and case management for children exposed to lead, the CDC US guidelines for identification and management of lead exposure in pregnant and lactating women, and the committee opinion of the American College of Obstetricians and Gynecologists on lead screening during pregnancy and lactation. Okay, so there was a lot of work that then went into putting together the draft Port Pirie clinical lead guideline. Many questions came up throughout the process that nobody could have anticipated in the beginning. So, for example, the CDC guidelines recommended testing for iron deficiency in all children with a blood lead level greater than 3.5 micrograms per deciliter. Now, there are hundreds of children in Port Pirie with a blood lead level greater than that. So, would our primary health care clinics and our pathology services, would they even cope with a sudden surge in requests for iron studies, for example? And at times there were differences in opinion from those in the working group. So some considered that best practice should strictly guide what went into the Port Pirie clinical lead guideline. And others took more of a practical approach and suggested that compromise was necessary in order to work within the limits of our resources. So it wasn't easy at times to know what route to take. But this also highlighted the need to ensure that there was an ongoing planned evaluation of the guideline once it was rolled out. So would our resources cope with the new demands? Would our clinicians find the guideline useful? Would it work in a practical sense? What impact would it have? Okay, and so I'm pleased to say that in April last year, the Clinical Effectiveness and Complex Care Committee within the York and Northern Local Health Network endorsed the draft Port Pirie clinical lead guideline. So we then had the task of taking on the role of a communications team. We had a few very talented staff at EHC who worked on putting the guideline into the correct format, on the appropriate templates. And in November last year, we finally went live with this resource on the SA Health website. So there was certainly a bit of a celebration at that point. So what then? Well, I went back to all of the clinics. I did a bit of a roadshow and introduced the resource to as many clinicians as I could in Port Pirie. I demonstrated how to access them from the SA Health website, gave out business cards with the QR code on them, which they could scan to bring up the guideline on their mobile phone. And at this time, I also collected some baseline data from about 30 of these clinicians. They completed a questionnaire, which I'd put together, and the questions related to information that was within the guideline. So my hope is that in the future, this will be useful because we can revisit these questions sort of 12 months down the track with the same target group. So that's a task that the EHC has now taken on. So there will be hopefully some ongoing evaluation of how it's working. And I was also given some preliminary feedback from GPs who'd been using the draft version because there were some GPs in Port Pirie who provided input on the development of the guideline. And this suggested, at least anecdotally, that it was already having a positive impact on routine clinical practice. Okay, questions. And if you don't have any, you can scan that QR code and check out the guideline. I'll stop sharing my page so I can see you all again and
Carmen, thank you so much. Fabulous piece of work. I'm staggered. It took 100 years to get a formal response with the lead implementation program.
Crazy, isn't it?
That's a long time.
It's very fascinating history, actually, and you could talk hours about the history, because when you look at where it started and where we've got to today, you can understand why it is as it is. But yeah, took a long time.
And it is tricky sometimes being public about major health problems, and how do you do that in a way that doesn't destroy a community at the same time? Um, I'd be interested in your perspective. I mean, you know, you've got a community there that has a public health problem that is clearly significant if you look at, you know, comparing it to global data. Um, what is your impression of the view of the community? Is it an important issue that they want to see solved as well, or
Mm.
are they part? Do they see themselves as part of the solution, or do they not want to talk about it?
Yeah, it's so variable because, you know, there's a spectrum of people who are so anxious about it. And then there are people who just say, oh, you know, my, you know, generations have lived here and they had much higher levels than what my kids have, and it's fine. It's, you know, so you do see such a difference in opinion among people that live there. I think on the whole, the population who we work with, those individuals who we really struggle with in getting their lead levels down, there's a combination of, you know, perhaps they don't see it as big a problem, or unfortunately, they just don't have the capacity to do what's needed to reduce their exposure. So I think people there do have a general understanding overall that it's important and that it needs to be addressed. But yeah, you've got competing interests. You need the smelter there for the employment for a lot of people. Um, and also, it's not really something that the council or the town want to advertise. It's not very appealing if you
Hmm.
put that message out there. And we've struggled at the Environmental Health Centre with things like, you know, we just wanted a sign that said Environmental Health Centre this way. You know, there's one for the hairdresser, there's one for the shops, but we couldn't get one for the Environmental Health Centre. It's not something that really they like to put out there, that they need an Environmental Health Centre. So it can be tricky in getting everyone on board for sure.
Hmm. Yeah. The other issue that sort of came out of your discussion was, you know, the need for clinical guidelines. Now, this is a contested area sometimes in medicine, in particular, where uh, some doctors are trained with the view that uh, every person is an individual, every doctor is an individual, and it's that doctor-patient relationship, and guidelines get in the road of that relationship. Uh, there's an opposing point of view, which is that you know, without guidelines, medical error is contributing to a large amount of the morbidity that we see in our health services and hospitals. You've now been involved in establishing some guidelines. What's your view of the place of guidelines when you say in your practice and a person comes in with diabetes? Do you immediately go for a guideline and follow it, or do you, if a person comes in with an upper respiratory tract infection, do you search for the guideline, or how has it affected your view of guidelines?
Well, I personally love guidelines because that's what they are. And they're a guideline there, and that was really something that we kept, I guess, saying the whole way through this process of making them, was that it's a guideline and that clinicians can make their own decisions with that patient in front of them. What we're putting out there is something that will just guide them and help them in making their decision. And they can deviate from the guideline if they needed to. But I think in this context, it was clear to me that a guideline was needed because there were so many questions being asked of the Environmental Health Centre, like medical related questions that we weren't in a place to answer. So the clinicians were really wanting something like this, or it was clear that something was needed because they didn't know what to do. And so I think, firstly, yeah, a guideline can be useful when it's actually wanted, which this one seemed to be, and also making sure that it was a guideline and there was no need to strictly adhere to it. And we said, like, with the recommendation for testing iron levels in children, a lot of parents don't want their kid to have a venous blood test. And so we said, well, that's fine. That discussion can be had with the GP. And we realized that a lot of people won't go on to have iron studies done of their child because they don't want that. So again, it was that, okay, you make that final decision, the clinician and the patient. And I think it was a positive, we had positive feedback around the way that we presented the guideline, in that it wasn't sort of this is the only way to do it. It was just, this is what evidence says, and this is here to help you. So yeah, perhaps how you present a guideline as well is important.
Another question it raises for me, Carmen, is what is the potential impact of medical or primary care medical intervention? So do we, to what extent what the doctor says or what the midwife says or what the child health nurse says, how much impact is that going to have?
Yeah.
When you're dealing with an endemic, ubiquitous toxin in the environment, we're not environmental agents in a way.
Right.
So what's your sense of the impact that health practitioners can have in this?
I think I learned from this that that clinicians have a much bigger impact than they might realize when it comes to public health issues or issues like this, for example, because we had the most knowledgeable people at the Environmental Health Centre trying to drum these messages into, clients of how important it was. But if their GP hadn't then backed that up, then we'd find people would sort of say, oh, well, if my GP doesn't care, it can't be that important. Whereas once we had a clinician or a primary healthcare provider that was on board with our messages, it made the world of difference to that family, because that message was just stronger and more consistent, and the importance of it then was more because everybody was giving that same message. And I don't think that the GPs and the other midwives and clinicians really knew that impact that they could have just by learning what that message should be, and then supporting it and repeating it with their patients. So I think that was quite important, and why I needed to increase knowledge about lead amongst them, because they a lot of them wanted to know more. They just didn't know where to start. So.
So last question to you. Fascinating presentation. Thank you. So how are you going to know whether this has worked?
Well, we've put together an evaluation plan. Unfortunately, I'm not there anymore, so it's now left in the hands of some of the EHC staff. At the EHC, they have a community development team, which is a team of 3 people. And so there is a plan that later this year, they'll revisit those clinics. And they will, we have a questionnaire that's been put together for, to be distributed at that time. So you've got your sort of formal things like questionnaires where you can gather data and see what effect it's having. And then the informal, especially in a smaller city like Port Pirie, like the informal feedback is also really important, because you do gather a lot of information just by talking to people. So hopefully that process will continue in my absence. Certainly some of the staff at EHC helped me get this over the line, so they are very interested in seeing how it goes. But yeah, time will tell.
Yeah. Look, thank you so much for updating us all on the impacts of lead. A huge global problem, 30 to 40% of developmental delay attributable to lead. That's staggering. When you think of how many millions of kids that equates to, in families, and employment opportunities that aren't realised, and all of the flow-on effects for that. And thanks for demonstrating the impact that one person with fresh eyes working in a team can have through applying a guideline lens to education. It's I do look forward to the evaluation. I wonder whether we need to think more formally about some research that could be undertaken there, and getting some additional funds for that, because I feel for the people in the EHC who are doing the work and being asked to do evaluation at the same time. That's going to be tough.
Yeah, they do a lot.
So thank you, Carmen, for the grand round, and thank you all for being part of this, whether you're listening at the time or you're listening to this later on. It's great to be part of an academy that is wanting to see excellence as the rule for rural health and rural health services, and part of that excellence is understanding the evidence that guides our decisions, and we've had a great example of that today. So thank you all, Nakan, and we will see you the next time.